Hi, my name is Dr. Jason van der Velde. I'm a pre-hospital emergency medicine and critical care retrieval physician. I'm but a simple rural Irish doctor with 5 kids who responds to an awful lot of trauma and at least a cardiac arrest every week. I have something a little bit out of the ordinary to share with you today. After changing something in my practice just over a year and a half ago, I have a 39% ROSC rate on arrival to hospital from all causes of cardiac arrest. That's right, 39% return of spontaneous circulation from all causes of cardiac arrest. Optimizing end-organ perfusion and oxygenation is key to achieving ROSC. To explain what we do in Ireland, a quick reminder of some basic CPR physiology. So during your downstroke of chest compressions, your intrathoracic pressure is obviously increased. Blood is propelled out of the heart and lungs towards the coronary arteries, the brain, and the rest of the body. The positive intrathoracic pressure generates a force that pushes gas out of the lungs. During recoil of the chest, the upstroke, a negative intrathoracic pressure creates a vacuum effect, pulling blood back towards the heart and lungs, and that negative intrathoracic pressure allows the lungs to naturally fill again. We all acknowledge that aspects of accepted practice are at odds with optimizing end organ perfusion and oxygenation during a resuscitation. For example, we pause during arrest to do tasks like pulse checks, CPR, operator changes, movements, rhythm checks, ventilation pauses, defibrillation, you name it. And each time CPR is suspended for any task, coronary perfusion pressure falls rapidly and requires about 10 to 18 compressions for perfusion to start to reestablish itself again. We've got to stop pauses. And professional responders breathe for people during arrests. And whilst we continue to do so, we inflict exceptionally high lung-damaging, asynchronous intrathoracic pressure increases, which significantly reduce coronary perfusion pressure. Current established ALS algorithms see us performing some technically exhaustive physical tasks while at the same time trying to figure out why the patient's arrested. We set ourselves up to fail from a CRM perspective. We're trying to think whilst we're doing all sorts of things that are absolutely physical. Think about it. Wouldn't you like things to be fully automated? Chest compression synchronized ventilation enables me to fully automate my cardiac arrests. It was a mode of ventilation that was developed exclusively for this purpose. It's the biggest CRM win in my management of cardiac arrest to date. Essentially, ventilation is entirely automated during cardiac arrest in synchronization with chest compressions. So this is how it works. The gas flow that's directed as you push down on the chest outwards of the lungs is sensed by a number of pressure sensors. That initial phase of the compression downstroke acts as your inspiratory trigger on the ventilator. That ventilator produces a pressure-controlled mechanical breath throughout the rest of that compression phase, i.e. exactly when you want the lungs to fill with air to provide additional, but crucially, controlled rise in intrathoracic pressure. Being synchronous with compression phase, the respiratory rate will equal CPR rate. Gas during recoil therefore escapes, which is the opposite of your conventional CPR physiology. The negative intrathoracic pressure produced significantly enhances recoil vacuum back into the chest, pulling more blood back into the thorax and greatly enhancing coronary perfusion. Cerebral drainage is greatly enhanced. And because you are providing PEEP through a ventilator, so is oxygenation. This is a real-world example. This patient's in cardiac arrest. You can see CCSV mode of ventilation. You will also notice that this patient in cardiac arrest has normal oxygen sats. The respiratory rate that you see there is equal to the rate of the chest compression. In other words, it's greater than 100. It's at a rate equal to chest compression. CO2 is removed during the recoil phase, but it's in very small amounts, relevant to what you would normally exhale. You saw that with the CO2 trace. At 2 mL per kilogram, it's a multiplying effect that is remarkably efficient at improving acidosis whilst focusing on oxygenation. And I have a number of case reports that I will be sharing that show exactly that. Crucially, chest compressions are never interrupted. It's becoming normal for us to have normal blood pressures during an arrest. And in case you're wondering, all of these examples are without adrenaline. This patient in VF arrest has a blood pressure of 104/51. No adrenaline, no inotropes, all because perfusion pressure is supported. Physiology aside, we know that human factors arguably play the greatest part in a successful resuscitation, especially during an emotive arrest, such as a highly public or pediatric arrest. Acknowledging their non-superiority, mechanical chest compression devices have been fantastically efficient from a CRM perspective, particularly for that rural or solo responder. Now that we have CCSV, the ventilation component is also automated. So I aim to optimize oxygenation and perfusion prior to working out the underlying cause of the arrest. In other words, truly achieving what the guidelines recommend prior to defibrillation. Fully automation not only allows us to clearly focus on the diagnosis and the management of the underlying cause of the arrest, it allows us to transport an arrested patient to definitive intervention. CCSV is the ultimate bridge to the PCI lab or to ECMO.